So I'm going to go through now some of the clinical elements of mitral regurgitation and when do you go to surgery. This talk used to be, but now this talk is now called when do you go to surgery or intervention, because it's not just always now surgery. And so we're pretty good at the anatomy. And the thing about mitral regurgitation, however, there's quite a long lag time or latency between when somebody first hears the leak with the stethoscope through when they have their first scan to when they eventually get to surgery. And sometimes many, many years can go by. Now, Dr. Ling, who's from Singapore, was at the Mayo Clinic and who was at Echo Australia last year, looked at, many years ago, was it a bad thing to have severe mitral regurgitation in its own right? And the answer, of course, it is, with a significant survival disadvantage if you've got severe mitral regurgitation. So what you want to do is you want to decide when to operate, the so-called golden moment to operate or intervene. So when you start with your mitral regurgitation, and now we're really talking about degenerative mitral regurgitation, that is good heart, bad valve, flail or something. When you start, you're actually very well. You've got a good ventricle, hyperdynamic, and you're very well. But as life goes on and things deteriorate, in particular ventricular reserve deteriorates, life goes downhill and you end up in a pretty bad place. So clearly you want to get and operate on these people or intervene on these people before you get to the point of no return where there's irreversible left ventricular dysfunction. But you don't want to go too early, because too early means you're taking all you're front loading your surgical risk before you really need to. And so the golden moment is not too early, not too late, the ventricle not wrecked, but still with some reserve. At the beginning, you start with a hyperdynamic left ventricle with ejection fractions above 60%. And when you've got a normal ejection fraction, in double inverted commas, i.e. 55 or so, you're already starting to fail this heart because some of that blood's going backwards. And by the time you get to the bad ventricle, and we're still talking about DMR here, not functional and DMR, but by the time you get to the bad ventricle, you've already missed the boat. Along the way, you get atrial fibrillation and pulmonary hypertension being a very late finding in DMR usually. It's not that common. But look where you get symptoms. Young, healthy people with young, healthy ventricles don't get symptoms till quite late down the pathway. And you certainly don't want to necessarily wait for people to be in heart failure before you decide to pull the trigger. So let's have a look at some of the things that you might think about when you're trying to make this decision, do I pull the trigger? So symptoms, obviously. So if you've got very little symptoms, i.e. NYHA 1 or 2, that is almost no symptoms, your survival is pretty good. But once you start to get symptoms, as we showed before, once you start to get symptoms, your survival is impaired. So if you wait for people to get symptoms, or if they have symptoms, you need to pull the trigger. One of the things that we know about in mitral regurgitation people is they get dysrhythmia, and they get two sorts. One is they get sudden death. And sudden death related to probably pap muscle ventricular tachycardia is obviously a malignant and terrible thing. And if you talk to virtually any heart doctor, he or she will tell you a story of some disaster that's occurred with somebody with mitral valve prolapse who's being watched, who gets cardiac arrest. And that's because they get polyfocal ventricular tachyarrhythmias and polyfocal ectopy. And certainly the ones that seem to have a lot of this would push us towards intervention early rather than later. Atrial fibrillation also would be a thing which would push us towards intervention in as much as we're further down the track. What about not DMR now, but FMR for functional mitral regurgitation? These are a whole different bunch of people. So DMR, good heart, bad valve. But FMR, bad heart, normal valve. And so in these people who are either ischemic or cardiomyopathy, you have problems with some sort of impairment of ventricular function, normal leaflets. We saw this business about ischemic mitral regurgitation, where you can have damage to either the lateral, the circumflex supplied, or the medial, the right coronary supplied pap muscle. It goes down and out. You saw this before earlier in the anatomy talks. And you get mitral regurgitation, which is functional and secondary to the wall motion abnormality, usually down one or other end of the valve, as you saw, and in fact more commonly down the right coronary end. Now, it's a bad thing, and if you do bypass surgery and you leave behind significant functional mitral regurgitation, there's a bad outcome. And if more than moderate, it should be intervened upon while you're in there doing your bypass surgery. Similarly, if you have cardiomyopathy type left ventricular dysfunction, global left ventricular dysfunction, bad ventricle, normal valve, your survival is substantially impaired if you have mitral regurgitation compared to if you don't. So functional mitral regurgitation as a marker of left ventricular dysfunction has a poor ominous portent. So what do you do about this functional mitral regurgitation? Now, back in the day, all you could do would be open heart surgery. I say that respectfully, Michael, all you can do. But nobody really want to have their chest cut open for normal coronaries, bad ventricle, severe mitral regurgitation. And it was a pretty big deal to go in, and this is what this fellow Steve Bowling did. I'll just go back. He'd put an undersized annuloplasty ring in Michigan to a whole bunch of people in the mid-1990s, or reconstructed the back of the ventricle with a plication type activity to bring the back of the heart in to let the mitral valve settle. And Steve Bowling, who I believe was truly a luminary, went very aggressively on this in the late 1990s, did several, I think a couple of hundred of these, and came back to us only just recently in the last 5 or 10 years and showed us really that there was no survival advantage, which was a very disappointing result for him and for all of us who thought we were doing a good thing doing open heart surgery for functional mitral regurgitation. Indeed, back in the day when we were doing the Batista operation in the Cleveland Clinic 20 years ago, we found that if you didn't deal with the functional mitral regurgitation, even if you made the ventricle better, you were left with a poor outcome. Now, as my brother says when you see this photo, when you talking about truly asymptomatic severe mitral regurgitation, and see this photo and what could possibly go wrong. So what about now severe mitral regurgitation with a good and vigorous ventricle? DMR people. Can you really leave them alone? Because pulling the trigger on open heart surgery for people who feel pretty well is a hard thing to do. It's a hard convince. And so what this paper says, and it looks like, there we go, 132 people who were followed up who were truly asymptomatic, they seem to do all right so long as their ventricle was vigorous. And indeed, if your ejection fraction's more than 60, i.e. you're on the left part of that curve that I showed you before, your outcome is actually as good as should be predicted for age. But if you're in the poor, or even not even poor, but double inverted commas, normal ventricular function phase, your outcome is reduced, and if you're in the significant left ventricular dysfunction phase, your outcome is markedly reduced. So even if you think you feel well, if your ventricle's going off, you're in trouble. What about how big is the leak? What is severe? How severe is severe? Well, as we saw before, we should be doing ERO, and 20 millimetres squared for degenerative would be called moderate, and 40 would be severe. But for the FMR people, different people, 20 millimetres square is a lot of a leak for a couple of reasons. One is the formula doesn't work that well, but the second thing is these are sick old hearts, and they really just don't have the horsepower to make as much observable mitral regurgitation, even if they're severe. Now, we grade these things 0 through 4, and in fact, everybody talks about quantitation, but in fact, doctors and sonographers are very good at doing this, and there's actually very good concordance with these visual numbers, despite the fact that they're categorical. Regurgitant orifice areas, 10, 20, 30, 40 square millimetres, easily to remember. And don't forget the business about late systolic regurgitation that Lisa showed us. So this person's only ejecting, and particularly the bileaflet mitral valve prolapse Barlow's people, this person's only ejecting for half of the cycle. So the systole might be 400 milliseconds. Using colour M mode, which I'm quite fond of, this person's only ejecting the flow backwards for 250 of that 400. So whatever you thought it was in millilitres, it's only 250 400ths of the amount of volume going backwards. On the other hand, functional mitral regurgitation tends to be pansystolic. And so the same looking plume going for 400 of 400 milliseconds is a much more significant amount of millilitres. What about if your heart's big? I've got some of these Barlow's type people, big, tall, athletic, and sometimes Marfan type body habitus. They've got quite big hearts. Well, it does turn out, back in the very old days, that bigger ventricles, badder outcome. But the thing about that is that all this data was done in the era where all we had, or what the main thing we had, was mitral valve repair, which at the time, back in those days, had quite a high risk. Now, Dominic Leung, who's from here in Sydney, and Tom Marwick, famous to all of us, have championed the use of stress echo, as you said, Lisa, for telling us not when to operate, but when we don't have to operate. If you've got somebody who you think is asymptomatic, and they think is asymptomatic, the ventricle's pretty good, is it safe to leave them for 6 months or 12 months, or do you really have to pull the trigger? And so what you're looking for is ventricular reserve. And what Dominic and Tom taught us from the Cleveland Clinic days 20 years ago is that if ventricular reserve is still present, if you've still got some left ventricular size decrease normally with exercise and contractility increase with exercise in your report, then you're going to be okay. Whereas if ventricular reserve is poor, you're already to the right on my deterioration curve, and it's time to get cracking. I'll just show you how we do stress echo in Queensland here. And I always like to see how satisfied she looks at the end of that. Just one last time. And the other thing to say is all our patients look like this. Okay. Now, what about the issue of definite repair? Now, there's a lot of hoo-ha about who's a good surgeon and who can do it. And I agree with Michael that not everybody can do a mitral valve repair, and I agree also with the folks earlier today who said that if you do more, you do better. And there's no doubt about that. And that if you're depending on your operating volume, you've got a much higher chance that you'll get a repair rather than a replacement. And certainly in the flail P2, that sort of anatomical DMR people, either a Cosgrove repair, which is something like this, where you put in a ring, or else a caudal transfer type operation from the Germans. One of these operations should end up with you having a competent valve. And if you have a competent valve, either the Cosgrove type or the German Leipzig type, then you should have a very good long-term result. And so that means low operative risk, good outcome, and if you don't have valve repair failure in the first year, unlikely to get it for a decade or more. This is now moving into the era where this can be done in the robot operating room. It's basically the same operation with smaller tools and being able to be done by remote, but the gist of it is still the same. But don't forget that mitral valve replacement is not a disaster. People kind of almost think of it as a consolation prize. Mitral valve replacement is a very good operation. And the mechanical valves work for decades. I've got one in now at 33 years with all the vagaries of warfarin, of course. Xenograft MVRs are very good, particularly in the older age group. I think in the younger age group, the xenograft mitrals tend to get pulled apart because their hearts are stronger. But don't belittle or underestimate the value of the mitral valve replacement. But the whole new world is about intervention. This is my colleague Bruce Garlett, cardiac surgeon, and he actually had to sell his loops just recently. So the mitral clip and others are here. And in fact, many centres around Australia are now using the mitral clip. I think we're probably approaching the 500 to 1,000 range done in Australia now in mitral clips. And there is a clear role for these. Remember, there are two sorts of mitral valve people. There are the DMR people who've got good hearts and a flail. And these are ideal for mitral clip if there's some good reason for you not having surgery. Because you go in there, you clip the thing, you catch the flail, they've got a good heart, and they go home the next morning fixed. The other sort of people, the FMR people, who've got a bad heart, normal valve, they're pretty easy to clip actually technically. But the thing about them is that the next day they still have a bad heart. And what you've done is take away the easy place for the blood to leak back into the left atrium and told them, no, I'm sorry, now you have to eject all your blood into the difficult place, that is the ascending aorta. And these people struggle a bit. It's an easy procedure from the technical point of view, but it's a hard procedure from the patient point of view. And they often require a lot of vasodilators, sometimes a couple of days of inotropes. They limp along for a month or two. But eventually, they need less Lasix for their breathing, they have less hospitalisations. So I think it is a good thing to do. But you have to have in your mind what you're doing and why you're doing it, because they're quite different people. We're going to hear later on about annuloplasty devices, a so-called the Carilion device, and there's the Valtech device. Both of these are in commercial marketing now, and they use respectively the coronary sinus and a percutaneous annuloplasty ring to try and bring the mitral annulus together, usually in FMR people where the leaflets are normal. I'd like to tell you about this device, which we've had experience with in Australia now through Genesis Care, which is the MAVERIC device, which involves the placing of a bar inside the coronary sinus, a string across the left atrium to a typical PFO occluder device, which is then pulled tight to pull the annulus together from posteriorly with the coronary sinus anteriorly to the aortic valve. This device here is a catheter which goes transeptally there, and it has a magnet on the end. This device comes from the neck to coronary sinus, and it has a magnet on the end. And again, as my brother says, what could possibly go wrong? Those two magnets go together, the black one in the coronary sinus, the gold one in the atrium, and they magnet to each other. They're hollow, and a spear wire is put through from the neck, through the wall of the coronary sinus there, into this receiving hollow tube here out to groin. And then this T-bar is delivered from this tube, string drawn through and pulled through this ASD device. So here's somebody who we're going into the room. Functional mitral regurgitation, I promise you there was just a tiny bit more than that when we started. Yeah, and they always look like that. Same as the mitral clips, because these people are empty with low pressure usually when you go on. Transeptal. And there is a device already here. The black catheter is in the coronary sinus. Transeptal here is got a catheter in the left atrium. The magnet then drags it down directly onto the coronary sinus, and this actually happens very quickly. And so you've got a magnet here inside the coronary sinus and a magnet cath in the left atrium. Then the string is drawn through. The T-bar is already in place here, and the string is drawn through all the way to the groin. An ASD device or a PFO device is placed as an anchor, and now the string is now on through T-bar here, loose at the moment through the ASD device, pulled tight, and then fully tensioned like this, and you can now see that there's been apposition. So supraannular annuloplasty, down from 3.5 centimetres down to 1.7, and now substantially less mitral regurgitation obviously there. Remarkable how these things work. The more things change, the more they say the same, eh, Michael? So past that is valve replacement, and we're going to hear all today about the Tendyne device, which is one of several now at market percutaneous mitral valves. These are all in the fledgling portal stage where you have to do an apical portal surgical, but they'll get to the transeptal angiogram stage pretty soon, and that will bring complete mitral valve regurgitation correction via the structural interventional pathway. So what are the current guidelines? You've already seen them, but let me paraphrase. The American approach is early identification of the problem, rapid workup, and early surgery if low risk. You might almost say it's a Trump approach. The Australian approach is a little bit more circumspect, early identification, symptoms and clinical state monitoring, use of stress echo to tell you when you can or when you cannot afford to leave somebody a little bit later, and operation much more on a needs basis using those triggers that we just talked about. So when do you intervene? This is the last slide. Obviously you intervene if there's symptoms. Obviously you intervene if you're doing a bypass and you're in the neighbourhood, you should fix the mitral regurgitation on the fly. Obviously you'd be more likely to intervene if it's a pan-systolic leak with lots of volume, if the ventricle's getting bigger or failing, but most importantly if the ventricular reserve or the exercise reserve or on stress echo is starting to go off. And you're much more likely to want to intervene if there's a high chance of repair rather than replacement, and clearly new technologies will change this paradigm. Thanks very much. Alrighty, we seem to be on time. Could I have the other speakers to come up and we'll just answer any questions? Have I got a microphone that I could use, please? So we'll go right back to Sean to start with. There you go. Actually, I'm going to stand here and you answer using that. So your question was, is there actually an anatomical abnormality of the mitral valve in HOCM people? Is the valve itself anatomically abnormal in hypertrophic cardiomyopathy?
There is actually a few studies done by the MAVERIC group that actually looked at MRI and the length of the anterior mitral leaflet. So in most people with HOCM, that anterior mitral leaflet will be a lot longer. And they've actually shown in patients who are genotype positive for HOCM and who are phenotype negative in the sense that they don't have the septal hypertrophy, you can see that their anterior mitral leaflet is actually longer than age-matched controls who are obviously genotype negative. So that's the main defect that can be seen there.
Very good. Okay, Michael, two for you. One is, do Australian centres actually publish their repair-replace percentage results?
Yes.
And where might a user get access to those things?
I think the ANZCATs.
So they're required to? Is that a requirement?
Yes. Yes.
Yeah, okay. Good.
But not every centre contributes to ANZCATs.
So yes, but no.
Yes, but
yeah, okay, good. Okay. Your second question, you answered the one about the role of the alpha area stitch, but here's the
Can I
thing.
just make a comment too about the obviously repair versus replaces? Not all valves, as we've talked about, are repairable or should be repaired. I think you have to take that sometimes with a grain of salt.
Okay. Your second question, in terms of wording, is there such a thing actually as anterior MAC, or should we use some other word like calcification of the aortomitral curtain?
I think you use either.
Okay.
My answer.
So that'd be yes, but no. Yeah.
Yes.
Okay.
I think as long as you're all speaking the same language, I think.
Okay. Lisa, your turn. So in the PISA calculation, is the forward mitral flow VTI or the VTI of the MR jet? Which VTI do you use to get your regurgitant volume?
For the regurgitant volume, you're using the ERO times the continuous wave VTI.
Of the regurgitation?
Of the regurgitant jet.
Yes, that's very good. Okay. Now, Michael? No, actually stay there, Lisa. What is the best way to quantify multi-jet MR? Do you just get, there's grade 1 over here and there's grade 1 over there, so that's grade 2?
I guess you can consider adding the jets together, but probably the best way down the track will be to use 3D colour planimetry and try and add them in that way, because you can see the maximal jet from a number of planes. Okay.
Now, Sean, one for you. Is a cleft valve not a congenital condition, and the indentations of the posterior leaflet are not true clefts? And we did kind of address this, but just let's clarify again about clefts, because there's an awful lot of hoo-ha about clefts these days with the 3D scanners.
So anatomically, so as we said, only that posterior leaflet has clefts or scallops, and they should not extend all the way down to the annulus. If it extends down to the annulus, then that's an actual abnormality and it's almost always associated with severe MR.
Okay. Alrighty. Now, I don't think we've had enough questions for Jason yet, so let's see if we can find one for him.
I've got one for you, Greg.
Okay.
Thanks for making comments about the use of strain imaging in severe MR. There's some recently published papers about using strain for a lot more these days.
Well, in fact, why don't you talk about strain for mitral regurgitation, because it is a pertinent thing, and it's a good opportunity for you, because you haven't got any questions here, so we'll let you talk about that. So strain's getting a life, isn't it? It's good for chemo. It's probably a good predictor for aortic stenosis surgery. So tell us what you want to tell us about mitral.
I think that we are using strain for early myocardial dysfunction. So there have been some recently published papers about the use of strain to detect some of these patients who may have early myocardial dysfunction and severe mitral regurgitation. And I think it should be a parameter we should be thinking about using both at rest and possibly with exercise.
So what are you really saying? You're saying the same thing that everybody's been saying for 20 years, and that is you want to catch these people before the ventricles go off. It's a bit like the Herceptin people. You want to catch them when they're about to go off. And so is strain going to be an early predictor, like it is in Herceptin, that the strain goes off before the ejection fraction? And it looks like it probably is, doesn't it?
I think it will be.
Yeah, okay. Good answer to your own question. Now, what about Michael, I'll get you to talk to this. What about long-term atrial fibrillation protection before, I guess, and after, more importantly, mitral valve surgery? So what do you do for fibrillation?
I resect every single patient's appendage and have done for years, regardless of whatever operation I'm doing. And I spoke about that to some controversy at our last meeting, but as we started structural heart, I could probably talk on whatever I wanted to talk on last time, so I did. I think atrial fibrillation, which is the thing people fail to mention, is atrial dilatation. I think you should look at as well in patients with mitral regurgitation, because that's the substrate for atrial fibrillation. So to have a successful repair but remain in atrial fibrillation, not have your atrial appendage dealt with, I don't think you've done the patient too many favours, because warfarin has its own fixed mortality and lifestyle and other problems. So yeah, I think you should take atrial fibrillation very seriously.
Okay, and one for James now, which just to give you a thing. So fantastic pictures and technology. Are we getting towards commercialisation of this, or is this still a laboratory PhD type activity?
So look, I think you'll probably see within at least the next year or next 2 years easy commercialisation. So already on some of the advanced workstations, you can essentially press a button to create a 3D file, and a couple of the other companies are now teaming up with 3D labs so that you can directly export to those labs for a 3D print of your heart. So within 2 years, you'll be able to press a button to receive a 3D printed heart.
Actually, I can imagine a thing like an espresso machine on our Echo that you just press the button and the heart comes out the bottom there. That would be quite good. Whilst 3D printing is all very cool, the cooler thing you showed us is actually doing surgery on the 3D model in the computer. So putting the tendine in, seeing where it's going to push and pull. How close are we to that? I noticed that we've been doing that on tendines in preparation we send it to the United States. How close are we to doing virtual surgeries in advance of the fact to say that a clip here or a plug there or something will fit or won't fit?
Yeah, so again, I think probably still a couple of years away, but again, now a lot of the TAVI, the more advanced TAVI software will allow you to kind of virtually implant devices, though the next step in terms of working out what effect that's going to have on flow or mechanical function, a little bit harder, but you'll be able to virtually implant things pretty easily soon.
Okay, so our last question is for you, Michael. You seem to get all the controversial ones. So it's a 7-pronged question. So it goes like this. Surgeons should have a 1% operating mortality for mitrals, but only allegedly, this person here who's looked up on ANSCATs and so on, allegedly only 50% of valves are actually repaired. I don't think that's quite true, but let's say.
I think that is probably reasonably true, actually.
Well, perhaps of all, but of
But
DMRs.
also, you have to be very, very careful about
Yes.
what is repairable and what is not repairable.
Yeah. So the question is, do all these Kaplan-Meier survival curves and everything that we show after mitral repair, do they really count in that that's only half of the people actually get into even to the entry level of those curves?
Yeah. I think it's very hard to know. They're often single centre. There's not huge population studies, single centre stuff with robust follow-up. And certainly in Australia, I think getting the data beyond 30 days is very, very difficult because patients go back to private practices and other institutions. So I think it's very hard to say, except that I know mitral regurgitation, we know if you let it go that and once they do get symptoms, people, even regardless of having a successful operation, have a 10-year less survival than someone without symptoms. So I think that's a very strong take-home message.
All right. So, and the last question, which is for you, which I'm going to answer for you, is what is the success rate of the Maze procedure? And the answer is obviously 100%, isn't it? I would have thought.
Always.
Yeah, always. Yes, good. All right, everybody. A round of applause for all the speakers there.